Good afternoon, everyone. My appreciation to the American Association of Orthodontics. I'm very honored to speak in this international meeting. And today we're going to share our experience with Miniscrew and maxillary protraction in class 3 adolescent patients. In this lecture, we are going to review the protocol describing the short-term outcomes as well as the long-term results after a 5-year follow-up. I'm a faculty member at the University of São Paulo, Brazil, located in Bauru, an inner city at the heart of the state, 300 kilometers far from São Paulo city. In our campus, we have the Bauru Dental School that has a special role in the development of dentistry in Brazil, and the Bauru Craniofacial Center that for many decades was the only craniofacial center in our continental country, and for this reason it has experienced a significant expansion. We invite everyone to visit us. I have no conflict of interest to disclose, and today MAMP, Miniscrew anchor maxillary protraction, is our main topic. However, before discussing MAMP, we have to overview two predecessors, the face mask therapy and BAMP, bone anchor maxillary protraction. I would like to tell you a story from backwards. This 18-year-old patient has received only phase 1 orthodontic treatment. And the question is, how was he treated during the mixed dentition? Now he is displaying inadequate facial aesthetics with a quite acceptable occlusion with only a minor space in the lower arch. And back in time, he was treated with face mask therapy at 7 years of age. Initially, he presented a class 3 facial pattern associating a maxillary deficiency and a mandibular prognathism. A class 3 anterior-posterior relationship with an anterior crossbite and deep bite was observed, and no OCR shift was present. He had a hypodivergent facial pattern with favorable prognosis for face mask therapy. And during treatment, the patient cooperated using the face mask and a lower bite plate. 1 year after treatment, an AP overcorrection was achieved. The SNA angle increased by 4 degrees, and a clockwise rotation of the mandible took place, decreasing the SNAB angle by 2 degrees. And observe here the longitudinal follow-up until the end of facial growth. A balanced facial profile was maintained over a 10-year follow-up, long-term follow-up. And a positive overjet was an indicator of long-term stability. And in this case, phase 2 was not needed. And what do we know about face mask therapy so far? First of all, face mask therapy reduces in 75% the complexity of class 3 malocclusions, thereby leading to a simplified mechanics during phase 2 orthodontic treatment. This evidence is from the University of Detroit. Number 2, we can expect a long-term stability in 7 out of 10 cases treated with face mask therapy, demonstrating a cost-effective therapy. And evidence from UK allow us to report that face mask therapy reduces the need for orthodontic surgery at the end of facial growth. 1/3 of patients treated with face mask therapy underwent orthodontic surgery compared to 2/3 in an untreated sample. And last but not least, using TEDs or hybrid expanders in the mixed dentition does not improve the skeletal effects of face mask therapy, as demonstrated by this new meta-analysis conducted at the University of Florence. In light of this evidence, we can consider face mask therapy as our gold standard. However, there is an age limit for indicating face mask therapy, as we've learned from these studies. And what can we do when a class 3 patient comes to us after this age window? Well, MAMP is an option for adolescent patients with a class 3 pattern. Let's turn our attention to our second patient. He had a unilateral complete cleft lip and palate with a moderate maxillary deficiency, and at the age of 12, he was treated with bone anchor maxillary protraction, producing facial improvements. The facial changes remained stable in the long term, and at the age of 20, an acceptable profile was observed. After MAMP therapy, the anterior crossbite was corrected and the orthodontic surgery was avoided. Bone anchor maxillary protraction was described in Belgium by Dr. Hugo de Klerk for class 3 adolescent patients. MAMP is a very simple mechanics using class 3 elastics anchored bilaterally on maxillary and mandibular mini plates. And in 2011, we started a research project in collaboration with Dr. de Klerk using MAMP in patients with unilateral complete cleft lip and palate. And all the patients had a moderate to severe maxillary deficiency. They are all surgical patients at the start. He has been to our center in Brazil several times, and the CBCT images of our sample were analyzed in collaboration with the University of Michigan by Dr. Sevdanes and Dr. Yatabe. A protocol specially designed for patients with cleft lip and palate was published in the AJODO. MAMP is performed 6 months after the secondary alveolar bone graft procedure using full-time class 3 elastics with 250 grams force on each side. Take a look at this 10-year-old male with a severe maxillary deficiency. He was treated with Bollard mini plates, and 1 year after treatment, the facial profile and the zygomatic prominence were improved. Initially, he showed a poor interarch relationship with an anterior crossbite. After MAMP therapy, a positive overjet was achieved. Compare here the change in the canine relationship before and after MAMP therapy. His facial convexity has improved with a change in the width appraisal of 7 millimeters. And this study described the 3D maxillary outcomes in a preliminary sample of 16 patients with UCLP treated with MAMP. In this study, we included all patients, even those who did not fully cooperate. Point A displaced 2.6 millimeters forward and downward with no difference compared to a non-cleft group treated with MAMP where the maxilla displaced 3.2 millimeters. And MAMP has also an effect on the mandible because no anterior displacement of the mandible was observed during treatment. Actually, a backward displacement of the mandibular ramus and condyles and glenoid fossa took place. And observe here in the superimposition of the CBCT images on the cranial base that no mandibular plane rotation was seen. The instability of Bollard mini plates was 4%, with most cases in the maxilla. Both the design of Bollard mini plates and the surgeon factor are important for this high stability rate. And MAMP improved quality of life, social interactions, and self-esteem as demonstrated by this recent paper. After MAMP therapy, we started the comprehensive orthodontic treatment, and class 3 elastics were used on the mini plates during the night time as an active retention until the end of facial growth. Today, our sample of 30 patients treated with MAMP is at the age of 20 with a post-treatment follow-up of 10 years. The good news was that we observed that all patients who achieved a positive overjet during MAMP therapy remained stable during phase 2 and orthodontic surgery was avoided. This was the scenario in 46% of the sample. Conversely, 54% of patients underwent LEFR1 osteotomy. Actually, surgical patients did not have an anterior crossbite correction during MAMP therapy, even though an improvement of the AP relationship has occurred. And what were the indicators for a non-surgical outcome, the desired outcomes? During treatment, we have a less negative overjet, a smaller mandibular plane angle, and a smaller gonio angle. And during treatment, greater change in the A and B angle and overjet increased the probability of achieving a non-surgical outcome. The lesson is the maxilla is the target, but the mandible is essential. And now let's move to MAMP therapy. That is a derivation from MAMP. Here we have another patient at the end of facial growth displaying a pleasant facial profile with a nice smile and an adequate occlusion at 17 years of age. He was treated with MAMP at the age of 10.5. Initially, he presented a class 3 facial pattern with a mild maxillary deficiency, observed the flat mid-face and the upper lip lying behind the lower lip. He was in the permanent dentition showing a class 1 relationship on the right and a class 3 on the left side. He had a right unilateral posterior crossbite and an anterior crossbite as well. The lower midline was deviated to the right with no COCR shift. The initial panoramic radiograph showed normality, and he had a negative width appraisal of 4 millimeters with a normal divergent pattern. Miniscrew anchor maxillary protraction is a MAMP-derived protocol where mini plates are replaced by miniscrews with the advantage of being a low-cost and a much simpler technique considering the orthodontist himself can place the miniscrews. MAMP uses full-time class 3 elastics anchored on a hybrid expander in the maxilla and on 2 miniscrews in the mandible. And this protocol is indicated for class 3 patients from 10 to 13 years of age. And the lower permanent canines should be completely erupted in the lower arch before starting the mechanics to the lower miniscrews. Rat maxillary expansion using palatal implants in growing patients were described by our group in Brazil in 2008. In 2010, the hybrid Hyrax using 2 anterior miniscrews for growing patients was proposed by Dr. Williams in Germany. And in MAMP, we are using a prefabricated Hyrax expander from PAC Lab Company, a Brazilian company, with two standardized Miniscrews of 1.8 by 7 millimeters as recommended by Dr. Lee. And the anterior region of the expander should rest on the first third of the distant part of the palate in a way Miniscrews are safely distant from the incisors and at the same time in a region with an adequate bone thickness. And there is no need for a bicortical anchorage considering the low rate of instability for monocortical Miniscrews at this specific region. Take a look at this clinical tip we have for you. If we compare the hard palate with a mountain, as we see here in the lake reflection, the Miniscrews should be inserted in the bottom third part of the mountain, exactly here where the palate starts to incline downward. And the hybrid expander planning is very simple and requires only two traces on the dental model. The center of the expansion screw should rest on the sagittal tracing, and the anterior limit of the screw should be placed exactly on this horizontal tracing located between the first and second thirds of the descent part of the palate. And the expander should rest 1 millimeter distant to the palatal mucosa. The expander is delivered, and then the Miniscrews are placed using the expander as a guidance in a direct technique. And the Miniscrews are inserted using a anterior angulation of 60 degrees in relation to the occlusal plane. And a conventional Hyrax expander with two anterior extensions made with round wires for the Miniscrews can also be used as an alternative to prefabricated expanders. In the mandible, the Miniscrews are placed distally to the lower canines at the mucogingival line, and a screw of 1.5 by 6 millimeters is the best choice. And thinner periodontal biotype is a contraindication for MAMP, considering the lower Miniscrews would be positioned too close to the alveolar bone crests. The details of MAMP technique were described, was published in 2020 in the Journal of Orthodontics. We invite everyone to read it. And now let's go back to our 10-year-old male patient. Rapid maxillary expansion was performed, and the mid-palatal suture split was observed. Then we started with full-time class 3 elastics using 250 grams force on each side. And a posterior build-up was placed in the occlusal aspects of the lower first molars to avoid occlusal interference during the anterior crossbite correction. And we can use ligatures in the lower Miniscrews to assure that the elastics don't touch the mucosa. Here is the progress after 3 months of treatment. And after 7 months of treatment, the appliance was removed. The patient complained of the minor space between the lower central incisors, and a 2x6 mechanics was used in the lower arch for 4 months to close the space. Isn't it a beautiful result? Positive facial changes were observed as we see here. And this is the final occlusion. After the appliance removal, a chin cup was used during the nighttime as a form of active retention until the end of facial growth. and treatment time was of 11 months, achieving adequate outcomes. The SNA angle increased 3.5 degrees and the overjet increased by 5 millimeters. The hybrid expander minimized the dental effects in the upper arch, but does not avoid it completely because we usually observe an upper incisor proclination and a slight mesial displacement of the upper first molars. And the superimposition of pre- and post-treatment CBCT images on the cranial base performed by Dr. Miranda, our new faculty member, together with Dr. Sevdanes, showed an anterior displacement of the maxilla, zygomatic bones, and nasal bones, the complete midface displaced forward, and observe here the anterior displacement of the temporal zygomatic suture. 5 years after treatment, at age 17, the results were quite stable, except for the eyebrows. And the occlusion was adequate. Remained very stable, the third molars have erupted, and the overjet remained positive. Here is another case, a patient displaying a moderate class 3 facial pattern with a hypodivergent growth. MAMP started at the age 11 and was maintained for 9 months, producing favorable outcomes and facial changes. The anterior crossbite was corrected, and observe the good control of the mesial displacement of upper first molars, because the lack of space for the upper canines was no longer compromised during MAMP therapy. And here we have the final occlusion after the comprehensive orthodontic treatment. And observe the orthopedic effect of MAMP in our patient while the maxilla displaced forward. No anterior displacement of the mandible was observed, and a backward displacement of the mandibular ramus and condyle took place during MAMP therapy, similar to changes we've observed with BAMP. 5 years after treatment, at the age of 18, the outcomes remain stable. And here we have a patient with a class 3 hyperdivergent pattern. MAMP therapy started at age 11 and was maintained for 10 months, producing facial improvements. The anterior crossbite was corrected. And here we have the orthopedic effect. While the maxilla displaced forward, no anterior displacement of the mandible was observed. After the bonding, we have the facial aesthetics was appropriate, and the occlusion was adequate. And 5 years after treatment, at the age of 18, the results were stable. During MAMP therapy, 15% of the lower miniscrews were lost and had to be replaced. Conversely, the upper miniscrews, the palatal miniscrews were quite stable, and only 2% were lost, confirming that the mid-palate is a golden region for miniscrew placement. And our randomized clinical trial evaluating the outcomes of MAMP therapy demonstrated that a positive overjet was achieved in 94% of the patients after treatment. And a recent three-dimensional study comparing that was performed in collaboration with the University of Michigan to compare MAMP and BAMP therapy demonstrated that both MAMP and BAMP produced a clinically relevant maxillary advancement of 2.2 and 3.4 millimeters, a 1 millimeter difference between the protocols. In the mandible, the effects of MAMP and BAMP were quite similar. No anterior displacement of the mandible was observed in either of the protocols. And a transverse increase of the nasal cavity was observed only for MAMP, considering RME is performed before the maxillary protraction. And 5 years after MAMP therapy, we observed that 4 out of 20 patients that were treated underwent orthodontic surgery, and 14 patients remained clinically stable. And a preliminary analysis of the long-term change in non-surgical patients conducted by our resident, Dr. Faber, who is here today, demonstrated that the A and B angle and the overjet remained quite stable over a period of 5 years after treatment. So we are very satisfied with these long-term results. And as a final considerations, MAMP is an alternative for treating class 3 adolescent patients, producing favorable facial and occlusal outcomes. MAMP is preferably recommended for patients with mild to moderate maxillary deficiency if we consider the amount of maxillary advancement we found. And a long-term stability was observed after MAMP therapy in most of our patients. Our deep gratitude to our research team, collaborators, and residents, and thank you very much for your kind attention.